Newfoundland and Labrador, of course, is not alone in this fight, as multiple jurisdictions across our country are facing the same challenges, whether it's with respect to delivery of care, provision of care, or provision of human resources. But we are finding creative local solutions that are working and will continue to work. We continue to work closely with our stakeholders, including Dr. Luscombe and the NLMA. And I'd like to begin by thanking Dr. Luscombe for negotiating a new blended capitation system of payment, a new model for our province's family doctors, along, of course, with my friend, Mr. Osborne. I'd also like to thank former Justice David Osborne for helping us resolve a few of the last outstanding issues, and I think we came to that collectively with mutual respect and agreement. We've reached a tentative deal that Dr. Luscombe will now bring to his membership on blended capitation. Blended capitation is a new model of payment for physicians that breaks a doctor's pay into two essential parts. 80% is basically an annual salary that is determined by the number of patients attached to a practice. And the remaining 20% is billed at a reduced fee-for-service model, similar to the traditional model that is currently in place. Essentially, the model pays doctors a set annual fee for each of their patients, plus a reduced fee-for-service each time they see a patient. That means their income no longer depends on the number of patients they see, so in turn they can take more time with patients to look after multiple issues in a single visit. This is another important step along our journey of reimagining healthcare for Newfoundlanders and Labradorians, and it speaks to our good relationship with the NLMA. We have built on other initiatives together, including $25,000 retention bonus for family doctors, the Remoteness bonus announced Monday, and of course the extra $200,000 for doctors to work in hard-to-fill rural areas that has actually helped secure 2 family doctors for Bonavista as an example. I want to thank everyone who helped make this a reality, including the hard-working officials in the Department of Health, and specifically my good friend, Minister Osborne. And with that, I'll turn it over to Minister Osborne.
Thank you, Premier. Welcome, everybody. When the Memorandum of Agreement between Government and the NLMA was signed last May, the commitment was made to establish a blended capitation model of payment. I'm delighted that our collaborative efforts with the NLMA have paid off and we've reached this tentative agreement. The agreement includes a 21% pay increase for family doctors, a bonus from government of $11,250 to help defray the costs of setting up a blended capitation group with other physicians, as well as an additional $10,000 from the Family Practice Renewal Program funding. It also includes a commitment from physicians in a blended capitation group to provide after-hours service based on the number of patients that they have attached to their group. Participation in a blended capitation practice is voluntary. Any physician can join the group or a group of physicians, and but physicians at any point can transition back to a fee-for-service model should they wish to do so. This model enhances our efforts towards comprehensive, continuous primary care. It also aims to improve recruitment, retention, and professional satisfaction for family physicians. The model is intended to attract new family physicians, while at the same time retain our existing ones. It also helps establish a foundation for interdisciplinary, team-based care for patients. The main benefit is continuity of care. It means a patient will be attached to a doctor who will now be practicing as part of a group of doctors, and this group may include other healthcare professionals such as nurse practitioners or registered nurses. It also includes a commitment from doctors and their partners in the group to see patients in a timely manner, helping keep them out of the province's emergency departments for routine medical issues. This truly represents a great arrangement for all residents of Newfoundland and Labrador, as well as our family physicians who wish to participate. I now ask Dr. Luscombe to make some remarks.
Thank you, Minister Osborne. Thank you, Premier. Good afternoon, everyone. I'm very pleased to be here this afternoon for this announcement. The Memorandum of Agreement between the NLMA and the Provincial Government included this commitment to establish blended capitation as a new payment model for family physicians. Negotiations for the new payment model began last summer and have recently concluded with a tentative agreement. We are very happy with the outcome, and we believe our members will be happy with this tentative agreement as well. Before the NLMA Board of Directors signs off on this new agreement, the NLMA will be holding a series of consultations with our family medicine members, including medical students and family medicine residents. Until our members are briefed, we will not be releasing the details of this tentative agreement. What I can tell you is that blended capitation will be a voluntary, alternate payment model for independent community family physicians. Many family doctors have told us that the current fee-for-service model in family medicine does not reflect the way that they are trained or the way that they want to provide care to their patients. Last year, we surveyed our family medicine members about blended capitation, and 84% of respondents said that they are interested in considering this type of payment model for their practice. This is also the preferred model of practice for most new family medicine graduates. They tell us they want to work in a model that allows them to provide more comprehensive care and promotes collaboration in teams. As mentioned, blended capitation works by compensating family physicians in two ways. One is an amount per patient per year for providing a comprehensive set of services to that patient. This is known as a capitation payment for each patient who is rostered to the doctor's practice. This is blended then with a separate partial fee-for-service payment from MCP each time the patient sees the doctor. This payment structure will allow family physicians to focus on the needs of the patient rather than volume of patient visits. This aligns with the way that family medicine learners are trained in this province to provide evidence-based care in a team-based approach. It gives doctors the flexibility to provide services in different ways so they can deliver a full range of care that encourages longer appointment times for complex patients, older patients, time for health promotion, patient education, and working with other team providers with the teamwork model. This is a much more professionally satisfying way to work, is what we hear from our members. We believe it will help retain doctors, as well as attract new doctors who want to practice under this model that has previously not been available to them. We believe that the new model will result in improved satisfaction for patients. Measures like blended capitation, new incentives for family physicians, forthcoming initiatives like family care teams, and a health human resource plan are all elements of an integrated family care system. We believe the culmination of these efforts will ultimately lead to better access to patients. Of course, today it's too early to see a major turnaround. We still have thousands of patients without access to a family doctor, but we are very pleased to see the government is doing the right things to address this crisis in family medicine. The NLMA will be closely monitoring these initiatives to make sure that these investments are successful and adequate. We need to see the net number of family doctors and other providers growing rather than declining in this province. We need to see better retention of Memorial University's medical students and residents, and we need to see results from international recruitment. The NLMA will continue to work collaboratively with the provincial government on these initiatives, as well as those outlined in our shared agenda on family medicine. We look forward to seeing continued progress. Thank you.
For the rosters, do the doctors decide who becomes a member of their roster, or how are the people assigned to a roster?
So some of these particulars of these models have not yet been determined. It would be anticipated. Some of the I would think that some of the things that would be considered would be like Patient Connect NL, which is actively rostering patients who are seeking family physicians. But again, those details aren't established.
Some of the family care teams to date have uploaded patients to the team, different than the question asked, but just so that you can see that we do have a strategy. Uploaded patients to a team, ensuring that there is the right balance of complexity. So it does no one any good to, for example, have 6,000 people rostered to a team, not to a physician, of course, who are 14-year-old active, healthy hockey players. Like that's not gonna serve anybody well. It'll look great on the stats, but that doesn't serve people well. So the health authority has and the department have done a good job in consultation with the stakeholders to ensure that the right balance is being achieved, uploading complex patients first perhaps, and then blending them, if you will, with less complex patients so that the provider is able to spend that right amount of time with people.
Is it just family doctors that are going to be eligible for this new, are they the only ones that are doing fee for service and the only ones that will be eligible for this? Like how does the current setup work? I'm not really sure.
No, so right now, both family doctors, well, there's some physicians, of course, across the province who are salaried.
Which would be mainly like ER doctors, that sort of thing?
No, it's a combination. There's surgeons who are salaried, there's family doctors, there's psychiatrists who are salaried. There's different, they would sign a contract in a salaried position with the regional health authority or the department. But by and large, most, I would say, Chris, or Dr. Luscombe, sorry, most physicians practice on a fee-for-service basis.
So currently, family physicians, our numbers are 75% would be in a fee-for-service model and 25% would be salaried. And as the Premier has alluded to, salaried positions are often maybe fairly rural sites that don't have high volumes. It might be working in a hospital, maybe, I know there's family doctors, for example, working in hospitals supporting tertiary programs like cancer, for example, right? So we're talking, this is really targeting the fee-for-service, community-based family practice in particular.
An important distinction, family practice versus specialists. Most specialists continue to be fee-for-service.
And will it only be family doctors that have this option?
Yes.
Okay. And will it be will new people hired for these jobs, will they have the option for a fee-for-service still versus this program? Will they be automatically?
Well, they'll be encouraged, certainly, I think, from most members. I think what we're hearing in med schools is no different than what you're hearing. This is the approach that they want. In fact, it's been done in many other jurisdictions across the country.
So this is voluntary,
But it's
and
still
the
voluntary.
fee-for-service system will still exist, but we anticipate that
There'll be
this will be
significant
very
uptake.
attractive. Yeah.
Any plans for a phase-out eventually, or is it just?
No, I mean, not necessarily, but again, I revert to the previous comment. What we are hearing from most new grads, certainly in the last 10 years, is this is the model that they want. They want, this allows them to spend the right amount of time with patients. So everybody knows, right now you get paid the same, in a fee-for-service model, you get paid the same to renew, you have to come in and have a quick check for blood pressure as you would for a new diagnosis of dementia, a new diagnosis of cancer, a new diagnosis of Parkinson's. The fee structure for that family doctor is the same. So we would think that changing this will entice people and make people want to be able to deliver the care that they are trained to deliver, to spend the time with the new dementia patient, the new Alzheimer's patient that is required and that they're trained to while being compensated for it. That's the feedback that we hear across the province and from medical students and new grads. And I think that it's a good initiative that there will be significant uptake with.
What does the 21% represent as far as an investment from government? What is there a dollar figure to attach to that raise?
We can get you that dollar figure, but we'll probably have that as early as this afternoon, I anticipate, yeah.
Yeah, I'm just thinking, I mean, we've heard the refrain, like if money was the problem, we would have had it fixed a long time ago, but this seems like an awful lot of money over the last couple of weeks.
So this is not money. What I've always said is that money is not the only solution, but it is a part of the solution. How can you create new infrastructure? How can you create new models? How can you create new technology without an investment of money? Continuing to invest in the old model is wrong. This is investing in a new transformational model that will lead to a sustainable healthcare system in the long term. If we were up here announcing that we were just investing more money in the old model, I mean, that's Einstein's definition of insanity, to continuing to do the same thing over and over again and expecting different results. That's not what we're doing. We're investing in a new model, and we're not alone in that. across the country. In fact, that was part of the discussions with the federal government, is to ensure that the new monies were not directed into old, outdated paradigms.
This
Yes.
is something the NLMA has been asking for a very long time. Why now?
Well, you know, right now is the time where we're looking at significant transformation within our healthcare system. You've seen it through the last series of announcements with respect to family care teams, which I believe is a key component to a sustainable healthcare system in this province, given the complexity and the challenges of geography and demographics. And so now is the time. You know, we had despite the challenges of the pandemic, everyone seems to forget that we were burdened with the pandemic with respect to the urgency in addressing issues. But despite that, we were able to launch the Health Accord, which helped inform us of some decisions and allowed us to have a more fulsome and constructive conversation with the primary stakeholder being the NLMA. So we have been open to solutions, and I think we've been responsive to solutions that have been brought forward, whether that's from the NLMA or from surgeons across the province and developing different models of providing surgical care, or you know, Heart Force One, listening to cardiologists. This is the time to transform the system because the old model doesn't work.
This obviously alleviates some stress on doctors to be able to see people at their own leisure in a way. What does this say, though, for benchmarks for wait times for patients? Is this going to be a situation where you're going to have to wait even longer for an appointment now if you're not in a high risk category?
No, I don't think so. I think what it will do is it will entice people to join the teams. So as we suggested yesterday in the announcement yesterday with respect to family care teams, that you will have access to primary care. And do you always need to see a doctor? Perhaps not. But you will always have access to a circle of care that involves a multidisciplinary approach. And I think that that's important. That's the change that is occurring throughout healthcare, not just in Newfoundland and Labrador, but around the country and in fact probably around the world. What this will do was it will allow the principal who needs to spend the time with the patient, whether that's a doctor, a nurse practitioner, a nurse, a physiotherapist, to be able to spend the time with the patient. I can tell you, having been on the other side, it's the pressure to see volume is intense. And sometimes you need to spend longer periods of time with patients. That's just the way it works. That's what leads to frustrating in the waiting rooms. But this model for primary care, which deals with the complex, fulsome nature of a patient, will allow that time to be appropriately spent with the appropriate provider.
If I could add to that as well.
Okay.
Part of the blended capitation model is ensuring that patients that are rostered to a team are seen in a more timely fashion, and there is a provision for additional after-hours appointments for patients as well.
And we're increasing the staffing levels, of course, through all the mechanisms discussed.
Right. And appointments will be categorized somehow, will they? In other words, if you're in to get a prescription, or if you're in to be diagnosed for dementia, how would that work?
Well, so you go ahead, but that's a bit different than the blended capitation. That would be, you know, through the family care team, the administration, and in often cases, the social worker, who's a patient advocate and navigator, would help determine where the patient is best, what provider the patient is best seen by. So if you require a blood pressure medication refill or renewal of your prescription, perhaps, you know, that's not the best use of the physician's time in that team clinic, and you know, perhaps that would be better with a nurse practitioner, and that's where the multidisciplinary aspect of this all comes together. In addition, of course, to the what I consider the true benefit is in working in a team and being able to lean on each other for advice and counsel, and ultimately with the common goal in mind, which is providing better care for not just patients, but patients plural.
So last word to Dr. Lascombe there.
Sure. No, I was going to say, I mean, these blended capitation models, while we can't speak about the specifics, you know, these are intended to be engineered so that there is a longitudinal relationship between a patient and the physician and that team. And now the physician should have more latitude to be able to mobilize other healthcare professionals to make sure that is done. And these models generally have accountabilities built into it so that these practices get right-sized. So you're going to have a population of rostered patients, and really there will be different monitors put in place to make sure that that's working and that the size is correct.
Dr. Luscombe, I guess you may have already touched on this, but what does blended capitation mean to patients? What's the benefit of blended capitation to patients?
I think, one of the biggest things is that this is transformational. This has been happening in other parts of the country, and now so Newfoundland is going to be on equal footing in competing with other jurisdictions to bring physicians into a model of care that they want. So that's going to help us to have more physicians practicing. And I think that what's going to happen then, if you have more physicians, you have more capacity. That improves access. But also, we're thinking that family physicians, physicians have always been saying that we have a specific role in a team and we can use help. And this model will help, can help to have other allied health professionals working in that team. So for a patient, you know where you're connected, you know that you're going to be taken care of, and that we think it's going to recruit more physicians into this practice to stabilize the system.
Just want to clarify one thing, just from the last announcement on the team clinics. When a physician who has an existing family practice moves to the team model, like rosters their patients over and is moved over there, are they going to be, because I was under the impression that those positions were salaried, so are those physicians going to be salaried with the team clinics, or are they going to be under this new blended capitation model?
Well, they really could be either.
Okay.
And depending on, the agreement that the individual physician has struck, we want to make sure that that his members have the flexibility to accomplish that. But we think that, and I don't want to speak for you, Dr. Luscombe, but that the feedback, that, again, repeating myself, but that the feedback that we've heard is that this would be a very attractive incentive to join a team clinic.
I think this is very complementary to that type of model. Fee-for-service in itself really didn't have mechanisms to allow cooperation in teams.
That's right.
So this can be an enabler. And of course, our association wants physicians to have some autonomy and control and choice. And we think that's going to help connect more of them into various types of practice, including hopefully the teams, which we haven't seen a lot of details on yet.
Because initially, the way that it exists currently is if you wanted to practice in a team, and that's the way we're being trained these days, you would have to set up that team yourself, which comes at significant financial expense. And if you wanted to be the physician who set up that team of support around you, which of course comes at significant risk, significant uncertainty, and what we are doing is taking all that away and saying, we value you, we value your skills, we think that they're best used providing primary care and not doing all that other stuff.
I know we have to get to the house. I just want to add to a comment or a question that you'd asked earlier, the benefit to patients. Patients belong to a team as opposed to a singular physician. There's an expectation of more timely access to physicians under blended capitation, including after hours.